Hey, the Grande Live. This is Coffee with Will, brought to you by Northwest Furniture and Mattress, Grande Ronde Hospital, Anything to Digital, EONI, Valley Realty, Schwab Tire, and Country Financial. And I am here today with Teresa Smith-Dixon, who is the clinical social worker and bereavement coordinator for the Grande Ronde Hospital. And she is here today to talk to me a little bit about herself and hospice. So thank you so much. Did I get it right?
Pretty good.
I was memorizing all of her titles before the show started here. And so it is actually National Hospice Month, correct? Mm-hmm. So it's National Hospice Month, and in celebration of that, we decided to have Teresa down here from her post up at Grande Ronde Hospital to talk to us a little bit about hospice and also what Grande Ronde Hospital has to offer. So thank you for joining me here today. Mm-hmm. So why don't you tell me a little bit about yourself and how you got into hospice?
Oh my, a long time ago. Back in the 70s, I was in college in Northern California and couldn't decide what area of social work I was going to work, wanted to focus in, and so I thought about children's services, but then I started visiting an elderly woman who wanted to die, and she was always talking about wanting to die, and
wow.
So I started visiting her and bringing her ice cream and listening to her stories.
Wow.
And she suddenly stopped complaining and didn't want to die anymore.
Wow.
And it was like that experience with her just opened up this whole world that I thought, wow. And then we started hearing about this hospice movement that was coming across the country to Northern California. And so a bunch of us started following Elizabeth Kubler-Ross. A lot of people have heard of her. She sort of took dying out of the closet. And
wow.
So anyway, we started, being groupies and following her and listening to her lectures around California. And
wow.
And so it went from there, because hospice really started as a grassroots movement.
Really?
Started in England, and they started doing research on how to, make people more comfortable through that horrible dying process.
Wow.
And so, and then that information came over to Yale here, and then the research started, and so they finally got in the early 70s, there was a hospice started in Connecticut, and then in Northern California in Marin County.
Wow.
But we really started as volunteers, teaching ourselves how to be helpful, present, in creative ways with patients that were being cared for, mostly maybe with some home health services and stuff, but it was really started as a grassroots movement, which a lot of people don't know that.
I didn't know that. So that's
it was
interesting.
A long time ago.
Well, but at the same time, it seems like it's a pretty recent movement. I mean, what age are we talking about
So
here?
we're talking about, a 40-year probably, like from when we got our first hospice in this country in about, I can't remember the year now. It's early, like 74, somewhere in there, early 70s. And so probably we're talking about is that about a 40-year spread?
So we've
a little over 40.
We've been caring for the elderly for generations, but we've only had hospice apparently for 40 years. So what's distinct about hospice?
Well, what's distinct about hospice is it's a philosophy of care for any age, of anyone who is terminally ill. And really, hospice started more with taking care of the symptoms, probably of dying from cancer. But as the field of palliative care has grown, and it's really a specialty, we care for people with chronic lung disease, the end stages of lung disease, renal disease, heart disease, Alzheimer's, dementias, and the specialty's grown to be able to address the needs of any diagnosis where there doesn't seem to be a cure, but to manage the symptoms of the disease.
That's so interesting. So hospice started out with cancer, but it grew as some of these more terminal illnesses came onto the playing field.
Yeah, and we started learning more about, wait a minute, these people are suffering too.
Yeah, for sure. So what? So what is sort of the standard of care that hospice brings to these people?
So hospice is only a place where a few, a lower number in the country have a hospice house or a hospice facility or a floor in a hospital. But mostly it's a home program. So we go to where the person lives, where they're feeling more comfortable, where they want to be, hopefully. And
so instead of them coming to you, you go to them.
Absolutely.
And that's where the term home hospice comes from.
Exactly. That's exactly true. And so we bring a team. If I was really not just me sitting here, I'd be sitting here with about 10 other people. We'd have nurses.
Someday we'll be able to have 10 on Coffee with Will. When NBC and Whole Foods decides to start sponsoring me.
You have to make a whole lot more coffee.
Hey, I like coffee. Not hearing me complain.
But there would be a nurse here. There would be a chaplain. There would be nurses' aides who help people with personal care. There would even be physical therapists and occupational therapists and of course social workers and the whole team. Plus, of course, there's the whole team. We have a medical director. And so we meet every other week to make sure that we're on top of people's care and that we're problem solving and staying current as a team.
Now, did you, so you had a very powerful experience with this lady when you were young, where your care directly influenced her, experience of her later years of her life. Has that left you with a sort of particular care for this demographic of people?
Yeah, and the demographic, is all of us. We all die. And so sometimes
I'm working on the scientific way of not dying, but don't tell anybody. I'm hoping I won't have to need your services, but just in case I do.
Yeah. I mean, there really is nothing that separates us from our patients because we're all, human and mortal. So, but what we care for all ages. Obviously not very often we care for children and infants even, but we care for all ages. If they have a terminal illness and want that supportive care, palliative care. So there's no real demographic, and of course, rich, poor, all of us, all of our.
So that kind of raises the question: is there more? And this is I don't know the answer to this question. Is there more of a need for hospice now since the 70s? Than before, or was it just more of a, hey, we really should address this problem that's been here for a really long time? Are people dying more from issues like cancer, like lung disease, like those kinds of things?
Well,
since
gosh,
that time?
Epidemiologist, I'm not, but
that's
but
okay. I don't know is a perfectly legitimate
either,
answer
but
on this
I think
show.
that a lot of it is, that's why it's nice to do this show, is to demystify what hospice is, let people know it is something that they could ask their doctor, to refer them for a consultation to see if it is what they need. So public education has probably made a big difference. There's still people who, hospice, kind of like the big C word, cancer, that it's like, oh, that means I'm dying right away. And really that's not true. Hospice, we really do better work when we get to care for someone over a longer period and can really get to know them, know what matters to them, and try to make some of those things happen for them. Give them lots of choices about how they'll be cared for if their disease progresses.
Sure. So let's talk a little bit about specifics about what would make someone choose to bring their parent or their grandparent or their loved one, as you're saying, their child or whoever, into a hospice situation. Because hospice can be expensive rather than doing it yourself, which could be cheaper if you don't take the time into consideration. Why would someone make the decision maybe to get involved with hospice for their loved one?
Well, first of all, the need. They've decided that they'd rather stay home and not go to the hospital constantly, to the emergency room to treat their symptoms, that they like the idea of having their symptoms treated at home or in wherever they live. They might live in assisted living or an adult foster home.
So this is not antithetical to assisted living. Like you can go to assisted living situations and actually do hospice.
Exactly.
Exactly.
Cool. So we are not a service that provides the meals, the transportation, Medicare developed a benefit package. And then most insurances have followed that. And we cover, of course, the staff, the expertise. We cover any medications for symptom relief. So if it is cancer, for pain and nausea, constipation, all the, anxiety, those medications we're supposed to cover. We cover durable medical equipment, like you might need a hospital bed or a wheelchair, something like that in your home. And like I said, we cover the staff that come. That one staff member might help you with your bath or shower a couple times a week. Social work will come in and help do problem solving or counseling around, how are we going to make this work in the home, maybe find some extra help to come in. And then the heart of our program really is our volunteers. They're the ones that get to go and do the creative. They can come and help someone write their life story or sit with a patient while the spouse caregiver goes out for lunch or for their haircut or for whatever they want, just for a break. Or to take care of their own medical needs. So it's that team approach that can be quite creative.
So do you find that how do you find people respond to these kind of care? Like, obviously, from what you were saying earlier, good. But is there specific, how do people feel when they know that they have a team of people who are coming to care for them? How does that make them feel? Have you seen changes in how people feel when, they're maybe before and after hospice?
Yeah, I think that one is, I don't know if maybe we're the same everywhere, but in a rural area, sometimes people say, well, I don't want all those strangers coming into my house. And so we start really slow and we get to know people, and that's why it's good to get a referral early enough that it's not in the middle of a crisis, so that we can build that trust and that relationship. It's so important. We all develop a relationship with our patient, and then we really, and the family, they're the core part of it too, and the caregivers. What I think is one of the great benefits of it is sometimes the patient goes, well, I'm doing fine, but the family says, oh no, I'd love to have hospice here, because they're making decisions about their loved one's medications and what their loved one needs. And there's no more suffering than when we feel we can't relieve somebody's suffering who we love.
Absolutely. It's almost worse than your own suffering when you're seeing someone who you love that is suffering, and you would almost give up your own sense of well-being to make them feel better.
Absolutely. And so what we do is empower them. We give them that sense of helplessness. We give them the kind of the education they need. We give them the tools. We listen. We give a lot of emotional support, because the role is hard, and they're grieving at the same time as doing care. So but our nurses do so much teaching that I always feel like it doesn't leave someone with, I wish I could have, would have, should have, I gave them too much medicine, I didn't give them enough. All those questions that can haunt us later after someone dies, they know they did the right thing because they were asking the nurse all along the way, what should I do? And they can call the nurse 24 hours a day and get that advice if something changes after hours or on the weekend. So I think it really helps for the long term too, that people feel like, okay, I did the right thing, and they feel good about themselves.
So this is as much for the family of the person who is dying as well as the person who is dying.
Absolutely. Absolutely.
So that's interesting, and it's interesting how you brought it into the realm of the power, because a lot of times we do feel powerless when other people are suffering, and this gives them a level of power to be able to do something, or at least let go of a thing to someone who knows what to do. I can see how that would be very reassuring. So that all being said, you said it was a very hard, it's a very hard position. My fiance actually did hospice for a while there, and it was very, and she did it, and she had a hard time with it because it was very emotionally difficult being around people who were dying. How do you and your team cope with that? How do you guys sort of, how do you cope with being in the situation with people who are at the end of their life, either for better or for worse?
Well, first of all, that's the part you can't change. We can change a lot of things. We can do the best interventions possible to help people get the outcomes they want and comfort, and not see somebody in pain or nauseous or, tons of anxiety. So that helps when we see somebody more peaceful. We all
Yeah.
feel better.
Yeah,
you know,
for sure.
the staff and the family,
Yeah.
et cetera, friends.
Yeah.
And so we do our best with that first, because then we can feel like, okay, we made a difference. I think everybody has a different way of coping. There's a lot of literature about vicarious trauma that we know that we do. You know, I always say we don't get out of this unscathed. I mean, you do choose a profession that you possibly are going to be changed by. In fact, you should be changed by it.
Yeah.
That you do look at your priorities, and that you do allow yourself to be changed by every single patient you have.
There's a quote in one of the Buddhist scriptures that says, it is a good thing to be consistently thinking on death. And I think it's a kind of an interesting take on things.
Exactly right. And same with the Benedictine. I know that Saint Benedict talked about keep death before you daily. You know.
Yeah. It
So,
changes your perspective. Yeah.
Exactly.
I'm saying that not from someone who is enlightened enough to say that happens all the time, but it's an ideal, so fair enough.
That's right. Yeah, but I think that what helps me, I think in the most essential sense, is that I see it as part, when I move that individual suffering or my own individual suffering into being connected with all humanity. It doesn't mean I don't have my sadness or my grief or feel that pain, but I also find meaning in that pain, or it's somewhat relieved by the fact that I am part of all humanity and that we all suffer on some degree.
Yeah.
And that is part of being human.
Yeah, that's really interesting.
So,
It's a thread that connects us all. There's a line from a Yevtushenko poem that reminds me of talking about the men, those who cannot suffer, and the people who take themselves out of it, to sort of take themselves out of love and of the ability to connect with other people.
Exactly. Yeah,
that's really interesting.
Yeah, you don't. If we don't love, we don't grieve. Then, so I guess if we love, we do grieve, and we do feel,
Absolutely.
Loss.
So now that all being said, so maybe someone's not quite ready to take that step into the hospice place. How could someone take a step to care for someone who's maybe in a situation like this on their own before they move into the hospice situation? What's something they can maybe do?
Oh yes, there's lots of education about caregiving online and stuff like that. So reading about caregiving and reading about the changed roles in your relationship, all levels, the hands-on things and then just reading about the emotional components to what you're getting into. I always tell families when they've jumped in, your mom falls and fractures her hip or whatever.
Yeah.
A crisis happens, and we jump in with both feet. We come, we help, we do what we can. But then when it looks like it's going to be sustained, that mom's going to need help over the long haul, we need to step back and do some planning, because we jump in with both feet. It's not really a sustainable system. But
you can't jump with both feet all the time. Eventually you have to start taking one after the other.
Exactly. So, that's what I always encourage people to do is, okay, sit back now. What do you need to do this over the long haul? How can you be sustained? What kind of breaks will you need? What kind of other people do you need to hire? Some people go to Department of Human Services, to the state, and apply through the Medicaid program to get in-home caregivers coming if they need a certain amount of care in the home. They can be evaluated for that separate. And sometimes when someone's on hospice, we do the same thing. But they could get that separately. There's a program at Community Connection called Oregon Project Independence that helps some people in the home with extra help, that kind of thing. And we also have, it's also Home Care Month. Actually.
Yes.
I didn't realize that at first, but
it
is.
Oh, really?
Yeah, and
so it's hospice care and home care.
Yeah, they just try to combine it. Well,
Fair
the
enough.
beauty is, what I love about our agency is we are licensed home care and hospice. So sometimes we're seeing somebody for an acute, post-acute, like something, they've been in the hospital, they go home, and we're seeing them for some rehab, or possibly, the nurses are working on healing a wound. Working on pain, working on different things, and those are skilled needs that home health provides. But it's usually time limited. You have a goal, you meet the goal or you don't. But sometimes then we start to realize that this patient, you know, they really start to verbalize, hey, you know, I'm just not gonna, I'm not really improving. I'm really just wanting to stay home and be comfortable. And we start hearing that kind of talk, and we start having honest conversations with, it might be time to transition to hospice. And so it's really lovely because we feel like it can be seamless with us. You get the same staff, same nurse, possibly same social worker, and it can be a seamless transition.
Wow.
So we really like that.
Very cool. Well, I think we're coming up on our time here. Do you have anything else you'd like to add before we take off?
Well, you know, my passion is grief support. I really love bereavement care, and one of the things that our community, our hospice does for the community is our. I don't know if I can put this out here.
You absolutely can. And they'll even look at it too. Look at that, Grande.
You'll see these around. And there are Light Up a Life Tree of Lights. For about 20 years, our volunteers started this program. We put a evergreen tree in Pat's Alley outside Fitzgerald's Flowers. They've always provided us with that space. And these little cards are available at our office and at Fitzgerald's and several other places, the clinics out in Union and Elgin, and the pavilion, the Grande Ronde Pavilion. And the card says, in remembrance of, and you can remember a loved one, and then it's who it's from, and a place to write a message if one wishes. And then we hang these on the tree through the holidays.
So it's kind of like a vigil.
It is, and then we have a little vigil. We do one night. We call it the tree lighting, and it's on December 7th at 5:30. And we read. We have some music. Our spiritual care coordinator says some words of insight to the group, and then we read all the names that are on the tree this year.
Oh wow!
And there's books there. We've written down every name that's ever been on the tree for something like 20 years.
Oh wow!
So the books sit by the tree. So if anyone's just wanting to, hang out in Pat's Alley, you can see names of many of our community
nice little alley.
members.
There's lots of little. It smells amazing because of the flower store.
Yeah,
so just so you know,
it's great. You can get your hair cut.
You can get amazing pizza, cock and bowl. It's like, oh man, you could just live there. Why don't you just let us live there?
So anyway, that tree's up there through the holidays. But we also do, we also have a grief support group twice a year that's done in the spring and the fall. And I call the group Growing Through Grief because it's not just about surviving.
Yeah.
It is about building resiliency. It is about finding life again.
Yeah.
Finding life, feeling like you want to live and feeling like you have purpose. And finding your unique way of doing that is what I love to do.
Absolutely, absolutely. Well, thank you so much for joining me on Coffee with Will today, Teresa.
Yeah,
it was super fun and very insightful. And thank you, Grande Ronde, for staying with us. This has been Coffee with Will, brought to you by Northwest Furniture and Mattress, Grande Ronde Hospital, Anything to Digital, EONI, Valley Realty, Country Financial, and Schwab Tires. Please like and share the video and tune into LaGrandeLive.tv for more local content. I'm Will Bowman.